Hi, I'm Bill Trattler, and I'm Director of Cornea at the Center for Excellence in Eye Care in Miami, Florida. And today we're going to talk about pterygium surgery, and in particular, how we can suppress inflammation after surgery to hopefully reduce the risk of recurrence in our patients. Since we're going to be talking about pterygium surgery and suppressing inflammation in and around surgery, I think it's useful to look at this diagram to understand the pathway of inflammation. With tissue damage, we get a release of phospholipids that get broken down by enzymes into inflammatory mediators. Steroids and nonsteroidal medications block various enzymes to block the production of these inflammatory mediators. If you have a more potent steroid, for example, the hope is that you can suppress the production of these inflammatory mediators. There have been a number of steroids that have been developed to help suppress inflammation. You can see that these steroids are listed here based on their order of potency, with betamethasone considered the most potent and prednisone considered the least potent of the steroids. We'll be talking about these steroids later in the program. Today we're going to be talking about a new steroid for the treatment of post-surgical pain and inflammation in and around pterygium surgery. Difluprednate, or Durezol, was developed as a dermatologic preparation and was licensed by Serum Therapeutics in 2006. Durezol was FDA approved in 2008 for the treatment of inflammation and pain associated with ocular surgery. Now, I've had the chance to use Durezol both with cataract and pterygium surgery, and it's been working very nicely, and that's why we're going to present more information on this today. One of the unique characteristics of Durezol is that it's an emulsion. I know we've all had experience using prednisolone acetate, which is a suspension, and we know that we have to inform our patients that they have to shake the bottle to make sure that the particles are distributed equally. We also know there's many differences in the formulation, such that, for example, the generics of prednisolone acetate require more shaking than the brand name. In contrast, with an emulsion, no shaking is necessary as the particles are equally distributed throughout the solution. One of the very powerful studies for me as I tried to evaluate this new steroid was a study that looked at Durezol for the use of anterior uveitis. In this study, there was a comparison of Durezol and Predforte, where Durezol was dosed at half the frequency of Predforte. You can see here from this diagram that for the first 13 days, Predforte was dosed 8 times a day, while Durezol was dosed only 4 times a day. Then these drops were tapered over the 1 month of treatment. For this study, here are the patient demographics. You can see that the Durezol group enrolled 48 patients, while the Predforte group enrolled 39 patients. You can see that they had similar age and they had similar demographic characteristics. This slide shows the primary endpoint for the study. You can see that the green bars are Durezol and the blue bars are Predforte, and just as a reminder, the Durezol was dosed at half the dosage of Predforte throughout the study. What's exciting about this study for me is that at all time points from day 7 on, the Durezol eyes had numerically better reduction in cells as compared to the Predforte eyes. This is another slide from this anterior uveitis study. You can see again that the Durezol eyes, which are the green bars, had clearing of anterior chamber cells, which means that the eyes were actually basically quiet, even though the dosing of Durezol started at 4 times a day and was tapered, compared to the Predforte eyes, where dosing started at every 2 hours and then tapered over the month. So I think this is, again, really reveals how powerful and potent Durezol is as a steroid for suppressing inflammation. One of the side effects that clinicians need to be aware of when using topical steroids is elevation of intraocular pressure. In this study of anterior uveitis patients, you can see that Durezol and Predforte both raise intraocular pressure in a small percentage of patients. With the information from the uveitis trial in mind, now we could shift gears and talk about the treatment of post-surgical inflammation. Again, one of the things that really helped me from looking at the uveitis study was to see that you don't need to dose Durezol frequently to get an excellent result in suppressing inflammation. I think it's useful to look at the 2 pivotal trials that looked at Durezol for the suppression of inflammation around eye surgery. I was actually one of the investigators involved in one of the studies, and you can see that patients were randomized to receive Durezol either 4 times a day, twice a day, or to receive placebo, and then they were tapered over 1 month of treatment. This is some data from the 2 pivotal trials. This slide shows the cleared ocular inflammation, which is where the cell count was less than or equal to 5, and the flare grade was 0. You can see that at all time points from day 3 on, the eyes treated with Durezol, either twice a day or 4 times a day, had much less inflammation as compared to the eyes treated with placebo. This slide provides some more data from the 2 pivotal trials. I think this is very relevant information. Basically, this slide shows the change from baseline in mean corneal edema. You can see that at all time points, the eyes treated with Durezol had thinner corneas, or less corneal edema, as compared to the eyes treated with placebo. Obviously, as a clinician and a cataract surgeon, it's useful because we want our patients to see better after cataract surgery, and it makes sense that if your corneas are thinner, you're going to have better visual acuity after surgery. Obviously, when we're talking about the use of topical steroids, we always want to again look at pressure rises. This is the data from the 2 pivotal trials. You can see that these are the number of eyes where the pressure was 21 millimeters of mercury or higher, and there was an increase in pressure of 10 millimeters or more. You can see that there was a low number of eyes in both Durezol groups and the placebo group that had elevation of pressure that met this criteria. Now, let's turn our attention to pterygium surgery. I practice in South Florida, and I see many patients with pterygia. I therefore end up performing a lot of pterygia surgery. When I remove the pterygia, one of the key things for me is to try to suppress inflammation after surgery, which helps to reduce the risk of recurrence and also keeps eyes whiter and quieter. Some of our key concerns for pterygium surgery is we want to prevent recurrence, we want to have a nice cosmetic appearance after surgery, and of course we want to avoid scleral melts, which occur if we use excessive cautery to the sclera or if the eye is very dry and we get a Dellin formation. Now in regards for my postoperative medications, for many years I've been using Predforte, but over the last year I switched to use Durezol for the vast majority of my cases. I've been using Durezol 4 times a day for 1 month, and then I taper the Durezol over the next month, and in general that has led to a nice cosmetic appearance and has helped me reduce my risk of recurrence. As you would expect, we also have to use an antibiotic to make sure we don't get an infection after surgery. Now here's an example of one of my patients that had pterygium surgery with an amniotic graft 1 month after surgery. You can see that there's very little inflammation, the eye is pretty white and quiet, and in general, over time, as the eye continues to heal, we would expect that this patient will have a very nice cosmetic appearance. I'm fortunate to work at my surgery center with Dr. Schaefer Sang, who's a noted authority on pterygia surgery. He was kind enough to share a few photos of a patient of his undergoing pterygium surgery. You can see from this intraoperative image that Dr. Sang is excising subtenon's tissue. You can imagine that this is quite pro-inflammatory and leads to a lot of inflammation after surgery. This next image is of the pterygium excised. You can see now we have bare sclera present. Dr. Sang then places an amniotic graft over this bare sclera to try to help reduce inflammation. You can see here in this image that Dr. Sang is squeegeeing and has now placed the amniotic graft in place, and now it is adherent to the ocular tissue. So now we have an image that Dr. Sang provided showing the same patient after surgery. You can see that the eye is white and quiet, there's no recurrence present, and obviously this patient is very pleased with the surgical result. However, not all our patients look so nice. You can see in this image that Dr. Sang provided that this patient has inflammation, which shows up as redness of the conjunctiva, and this patient is at high risk for recurrence. To try to help reduce the inflammation, Dr. Sang injected Kenalog, which is a very potent steroid, into the subconjunctiva, and you can see that now that same patient has reduced inflammation. So these 3 images help us look at the consequences of not controlling inflammation after pterygium surgery. You can see the first image shows the pre-op pterygium. Then 1 month after surgery, you can see there's inflammation present. And now you can see the final image of a patient 7 months after surgery and now has an early recurrence. You can see there's still plenty of inflammation present. This helps demonstrate the importance of suppressing inflammation with pterygium surgery because if you don't, your risk of recurrence goes way up. To better understand the impact of inflammation after pterygium surgery, Dr. Sang conducted a study of 27 eyes. 3 to 4 weeks after surgery, he evaluated those eyes and put them into 2 groups. In group 1, these were eyes without inflammation. He had 16 eyes, and he found no eyes developed recurrence. He ended up with 11 eyes that had inflammation present at the 1-month postoperative visit. Of those, he injected triamcinolone in 7 eyes and thankfully had no recurrence in this group. However, in 4 eyes, he did not inject the steroid and he had a high rate of recurrence, 50%. This study showed that suppressing inflammation is critical to preventing recurrence after pterygium surgery. Therefore, it makes sense that we want to use a very powerful and potent steroid following surgery, and I think that's why Durezol works so nicely in my hands for my patients undergoing pterygium surgery. So in summary, I think I'm very fortunate to have a new steroid, Durezol, to help with my patients undergoing pterygium surgery. I think we all understand how important it is for our patients to have white and quiet eyes. Patients expect an excellent cosmetic result, and of course, we want to avoid a recurrence. So I think with this new steroid being available, I think you will see that your results with pterygium surgery are much improved, and hopefully your results will be better and you'll have less risk of recurrence. Thank you so much for watching.